In this podcast episode, Dr. Nolan Williams, a triple board-certified neuropsychiatrist and founder of Stanford's Brain Stimulation Lab, discusses groundbreaking work on Ibogaine, a plant-derived compound with transformative potential for treating addiction, PTSD, depression, and even traumatic brain injury. Dr. Williams' scientific insights, clinical experience, and exploration into the mechanisms of Ibogaine underscore a paradigm shift in how we understand and treat mental illness, moving beyond traditional medications toward more integrative neuroscience-based approaches. The conversation begins by highlighting Ibogaine's unique origin as an African root bark psychedelic traditionally used by the Bwiti people of Gabon for ritualistic life transitions. For centuries, the compound has been recognized for producing profound psychological experiences, notably a life review, where individuals re-experience emotionally charged memories from a neutral, observing perspective. This psychological effect appears intrinsic to Ibogaine's power to reframe trauma, potentially reshaping how memories and emotional pain are processed. Unlike other psychedelics, such as MDMA, where guided therapy often accompanies the journey, Ibogaine's biochemical action autonomously facilitates this introspective process. Dr. Williams emphasizes that contemporary psychiatric treatments have long relied on oversimplified single-key, single-lock pharmacological paradigms, targeting one neurotransmitter system such as serotonin or dopamine. In contrast, Ibogaine acts as a dirty drug affecting multiple neurotransmitter systems, including dopamine, serotonin, and glutamate, along with neurotrophic factors involved in brain repair and plasticity. This broad spectrum of action may explain its remarkable effects across several conditions that traditionally seemed unrelated, such as addiction, PTSD, and brain injury. The science around Ibogaine's mechanisms elucidates why it is uniquely effective in these complex neurological and psychiatric disorders. For addiction, Dr. Williams describes how Ibogaine boosts glial cell-derived neurotrophic factor, GDNF, which helps restore dopamine neuron health, particularly in the ventral tegmental area, the brain's reward system hub. Rodent studies referenced by Dr. Williams show that Ibogaine administration stops compulsive alcohol consumption, mirroring findings from other models where direct infusion of GDNF or electrical stimulation in the same reward centers reduces addictive behaviors. This dopaminergic reset has clinical implications for detoxification. Ibogaine remarkably interrupts opioid withdrawal symptoms abruptly and physiologically rather than merely suppressing cravings psychologically. This differentiates Ibogaine from conventional addiction treatments, offering a potentially life-saving, rapid intervention. Furthermore, Ibogaine modulates NMDA receptors implicated in trauma-related excitotoxicity, calms overactive brain networks like the default mode network that reinforce rigid self-referential thinking, and enhances brain-derived neurotrophic factor, BDNF, which supports neurogenesis and synaptic plasticity. These actions underlie its capacity to promote healing, even in structural brain injuries where damaged neurons and disrupted networks typically resist recovery. Despite its promise, Ibogaine presents inherent challenges regarding safety, primarily due to its effect on cardiac electrophysiology, specifically prolonging the QT interval, which can precipitate fatal arrhythmias, such as torsades de pointes. Dr. Williams points out that the risk has historically limited research and clinical use, especially outside closely monitored medical settings. However, he contextualizes this risk by comparing it to already approved cardiac risky medications like ticosin, dofetilide, used to treat atrial fibrillation, arguing for a risk-benefit perspective in the face of overdose mortality rates from untreated opioid addiction. One key mitigating factor is the adjunctive use of magnesium therapy, a safe and well-understood compound routinely employed in emergency medicine to stabilize arrhythmias. Administering magnesium proactively before and during Ibogaine treatment appears to reduce cardiac risks significantly, but intensive monitoring remains essential. Dr. Williams envisions that current and future Ibogaine analogues, some chemically modified to retain therapeutic effects while minimizing cardiotoxicity, may eventually allow safer, possibly outpatient administration. Much of the data Dr. Williams and colleagues have gathered originates from observational studies with veterans suffering from PTSD, brain injury, depression, and addiction, conditions often co-occurring and resistant to standard therapies. He highlights a recent study published in Nature Mental Health demonstrating measurable, lasting neurophysiological changes after Ibogaine treatment, including generalized EEG slowing correlated with symptom improvements. Moreover, functional MRI and innovative AI analyses estimating brain age found that brains appeared on average 5 years younger 1 month post-treatment, an unprecedented marker of brain restoration and plasticity. Remarkably, these veterans experienced dramatic clinical improvements, with depression symptoms reducing by over 80%, PTSD symptom severity falling by nearly 90%, and anxiety showing similar declines. Disability ratings in traumatic brain injury cases dropped from moderate to near normal function. Such effect sizes dwarf those typically seen with pharmaceutical antidepressants and anxiolytics, which often demonstrate marginal benefits against placebo. Beyond disease treatment, some individuals also seek Ibogaine for cognitive enhancement, reporting improved executive function and mood regulation. Although this aspect remains less studied, it hints at broader applications for brain health optimization and longevity. The interview also contrasts Ibogaine with other emerging psychedelic therapies like MDMA and psilocybin. MDMA-assisted psychotherapy, for example, typically requires intensive guided sessions wherein the drug facilitates emotional openness and processing within a therapeutic framework. Ibogaine differs by inducing its psychospiritual life review autonomously without requiring integrated experiential facilitation during dosing, although post-treatment therapeutic support is advisable to help patients process intense memories and emotions. While other psychedelics may have rapid onset but limited duration of action and smaller neuroplasticity effects, Ibogaine's complexity and extended neurochemical impact may produce longer-lasting brain resets that fundamentally rewire maladaptive circuits underpinning addiction and trauma. However, these benefits come with a more complicated safety profile and longer treatment sessions spanning 24 to 36 hours, a consideration for scalability and accessibility. Dr. Williams situates Ibogaine within the evolving landscape of psychiatry, moving towards circuit-based models, where mental illnesses are understood as dysfunctions of specific neural networks rather than solely symptom clusters or isolated neurotransmitter imbalances. This integrative neuroscience perspective enables combining pharmacological, neurostimulation, metabolic, and psychotherapeutic interventions tailored to modulate brain circuits more precisely. He draws parallels to other successful multimodal treatments, like combination cardiovascular therapies, suggesting that future psychiatric care might integrate metabolic optimization, nutritional psychiatry, and psychedelic-assisted neurorehabilitation. The possible synergy between metabolic and psychedelic psychiatry promises to accelerate and amplify recovery, addressing the overwhelming global burden of mental illness, with half the world's population facing a DSM diagnosis at some point. Currently, Ibogaine remains a Schedule I substance in the United States, complicating research efforts. Nevertheless, increased funding, exemplified by a $50 million research initiative in Texas, signals growing momentum to rigorously evaluate Ibogaine's safety and efficacy through controlled trials. Dr. Williams expresses hope that within 5 to 10 years, formal FDA-approved studies will allow safe, scalable use in clinical settings. Until regulatory frameworks evolve, treatment seekers often travel to clinics in Mexico and elsewhere, where standards and monitoring vary widely. Dr. Williams cautions that, due to inherent cardiac risks, Ibogaine administration must be undertaken in medically supervised environments with proper safeguards in place. As the dialogue closes, Dr. Williams and the host muse on the broader implications of harnessing Ibogaine's multifaceted mechanisms for neuropsychiatric healing. They question how such powerful plant compounds, long marginalized or criminalized, might reshape societal understanding of mental illness, shifting stigma toward a model recognizing tangible physiological and circuit-level brain dysfunctions. Reflecting on the historical journey of other plant-derived compounds like vitamin C, they underscore the need to overcome entrenched biases and regulatory obstacles to unlock these natural medicines' full potential. The interview captures a hopeful moment, a confluence of ancient ethnobotanical knowledge and cutting-edge neuroscience, promising transformative solutions for some of the most intractable challenges in mental health, addiction, and brain injury.